Hello, hello, and welcome everyone. It is Wednesday night. That must mean it is time for some KFP practice questions. My name is Kane Treble. I'm a GP based out of Mildura, Victoria, and I'm here tonight to share some tips and tricks to get you through the RACGP KFP exam. Good to have you all here. Good to see already some familiar faces in the chat there, and I am going to be trying something a little bit different tonight. I did this right at the start of these live streams where I would actually read the question in the question time, and I'm going to bring that back for the purposes of hopefully turning this into a podcast as well for the people that want to be able to listen to this while they're driving or wrangling kids or doing any other thing you would normally do in life, so that they have the opportunity to participate in their own way. Of course, we are coming up to the KFP exam. Let's just bring this up here. We are 87 days off from the 2024.2 KFP exam. So again, lots of time left to be able to hone in and practice your exam technique. Make sure you cover your areas where you're not feeling as strong, which brings us to the topic of teaching for tonight is a combination of self-care and identifying where you need to look after yourself. It sounds stupid. We tell everyone else how to look after themselves, but we are often very bad at actually following our own advice and looking after ourselves. So please, 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 in these few months left before the exam, make sure that you get enough sleep, that you are eating well. Don't eat leftovers. Particularly important in the final stretch before the exam, and before the exam itself, I'm going to be putting that in there to make sure that everyone's aware of it, because you don't want to be getting food poisoning or something like that just before. Make sure leading into this exam as well that you are taking regular breaks. You're setting time aside to make sure that you are valuing your family, valuing your friends, getting out there and doing more than just study, just work, because you're doing yourself a disservice by ignoring the rest of your life. Particularly in this stretch now is the time to make that time for that, to make sure that you're not letting this one exam take over every aspect of your existence. Practice mindfulness. I know it's one of those things we often tell patients to do, but something that I've found most doctors don't actually try themselves. Download some guided mindfulness apps. They work wonders. They really do work. And make sure, of course, you're exercising as well. Now, of course, that's not being very specific there. Let's make sure that you get 30 minutes of exercise for at least 5 days per week. Does this sound familiar? And it's a bit weird when I'm here hosting a live stream on a Wednesday night, but do try and avoid cramming at this point, which brings me into our next slide here. Pardon me. I want you to have a look. Where do you think your weaknesses might lie? This section here, this little picture, is ripped directly from the RACGP 2022 curriculum. It's available on their website, and I've put a link into the description for this video tonight as well. Click through because this actually lists the different domains or clinical competencies. How great's that when you can't say the word competency? Guess that makes me incompetent. It covers the different domains that they want you to know to be able to pass this exam. This is a nice way to quickly have a look and say, yep, okay, I know I'm not fantastic in this area. Click through, follow those pages. You are going to find some really incredible information on how to hone in on those areas, types of resources that you should be paying attention to, and there's even a couple of common traps and things that is good for clinical practice that you may see appear time and time again as exam questions. They are doing what they can to give us as much information as possible to prepare us for the exam, and I think a lot of us don't even realise that these kinds of resources exist. I'll not harp too much about it tonight, but I really want... pardon me, there's that cough. I really want you to know that this exists and know that it is something that you should be aware of and tap into. Of course, we're all here tonight to practice our exam questions. So we have case number 1 for tonight. Let's get 2 minutes on the clock, and of course your time starts now. A 12-year-old boy named Sam is brought to a rural GP clinic by his parents after being bitten by a dog on his right hand while playing in his neighbourhood. Sam reports that the dog, a large mixed breed, was unfamiliar to him and the incident occurred when he attempted to pet the animal. He describes feeling a sharp pain and bleeding from the bite wound immediately after the accident. His parents report that the dog ran away after biting Sam. Sam's last tetanus vaccination was 4 years ago. On his right hand, you observe 2 puncture wounds on the dorsum of the hand, approximately 1 centimetre apart. Active bleeding has stopped. Question 1.1. What additional aspects of examination might suggest a more serious injury? List 6 additional aspects of examination. Alright, time is up and let's have a look at what some of the answers could be. So really focusing in on what this question is asking, what additional aspects of examination might suggest a more serious injury. Lots of targets here. So the big thing that we really wouldn't want to miss and would be worth definitely 2 marks is neurological deficit distal to the wound. That would hint at nerve involvement, which would significantly escalate our concern on this case. Likewise, and often overlap, we often say neurovascular, but in this exam, we want to split those apart because they are different types of injuries. So evidence of vascular compromise, or with that, you would probably also get away with mentioning things like duskiness or poor capillary refill distal to the wound. Again, 2 marks there. Of course, any evidence of joint involvement, and here there is a little bit of ambiguity as to exactly where this bite is, and that's intentional here. We want to make sure that we don't have a joint space involved, and probably tied into that as well would be abnormal range of movement or restriction in range of movement. Now, of course, if there's any evidence of bone pain, that last one would be worth 2 marks. If there's evidence of bone pain or traumatic fracture, that's going to get you another mark. And the way we would assess for that, of course, is pushing distal and proximal on the bony prominences around the wound. If there's any kind of tendon sheath involvement, you could argue there is some overlap here between abnormal range of movement, as mentioned before, versus this. Really what we're starting to look for are things like our tenosynovitis type injuries. Erythema surrounding the wound, again, looking for infection, warmth around the wound on that same front, or any pus or exudate from the wound. Now, you'd be pretty unlucky if so soon after a bite, again, the time frames are intentionally a little bit vague here, you have any of these signs there, but certainly something that you would be concerned about. And of course, systemic features of illness, so things like fever over 38 degrees. So we've got some answers here from the chat. So loss of finger active finger extension. Yep, fantastic. So that's the abnormal range of movement. Cap refill impaired. Visible tendon damage in the wound. Fantastic. Numbness of fingers. Yep. So I do like numbness of fingers, but I probably would aim to be more specific to mention exactly what you are concerned about there. And if you're having capillary refill, no, I think I'd accept that actually. I would say probably specify neurological deficit. Hypertension, tachycardia, signs of systemic illness or sepsis. Yep, fantastic. I think you would probably get that lumped in with the fever as systemic features of illness there. So well done. All right. Of course, we've got a part 2 to this question. So let's get 2 minutes on the clock and your time starts now. Sam's parents ask whether he'll need antibiotics, as his younger sister had a cat bite last year that needed some. What risk factors would increase the risk of wound infection requiring presumptive therapy? List 4 specific risk factors. time is up. Let's have a look at some answers. So the kinds of things, and this is again taken from ETG, which really is the Bible when it comes to finding out what we should be using where. So the things that would have us concerned here would be if the wound is a cat bite. Now, you will notice with this question, it just asks what risk factors would increase the risk of wound infection requiring presumptive therapy. It doesn't specify for this case, for this patient. So we do have that as a potential option here. So that's definitely worth a mark being, is the wound a cat bite? Presentation to medical care being delayed by 8 hours or more. I think if you were to just say delayed, you'll probably get half a mark. Showing that 8 hours or more is going to give you really that extra consultant level knowledge that'll get you the full mark or potentially even 2 marks in the actual exam. Now, if the wound is a puncture wound that cannot be debrided adequately, is also going to be in higher risk. You're more likely to have foreign contamination trapped inside that wound, which will increase infection risk, as well as if the wound is in a high-risk location, so hands, feet, face. If the wound's involving deeper tissue, such as bones, joints or tendons, as you probably noticed from the last question, someone mentioned, is there a tendon on view or involved? That's certainly going to increase your index of suspicion. As well, does the wound involve an open fracture? Of course, is the patient immunocompromised? Are they going to have potential for an impaired immune response that might mean they may not mount a proper response against even mild contamination? Or, of course, the patient has a high-risk comorbidity such as alcoholic liver disease or diabetes. So those last two, really we're talking about that immunocompromised state, and so they're likely to be grouped together. So I wouldn't be having both of those answers in the exam. Alcoholic, immunocompromised or asplenic individuals are going to be in that much higher risk category for capnocytophaga, canemosis infections. So you're going to want to make sure that you're covering for those adequately. We have some answers coming in from the chat, of course. So joint involvement from the wound, fantastic. Previous solid organ transplant, excellent. And you're coming into that immunosuppressed state. Visibly dirty wound. Not specifically mentioned here, but I think I probably would agree in terms of a heavily contaminated wound. Yeah, that's going to get you a mark. As for extremely remote area, that's potentially a little bit risky. And I think I would probably go for other options just because remoteness, I'm not sure, given the increased availability of things like telehealth these days and the fact that this has been flagged, you'll be organising a review, I'm not entirely sure if that would get you over the line for empirical management. There is a real push for antibiotic stewardship these days, and so there is that reluctance to just prescribe antibiotics, and really we're trying to find more and more reasons why not to give antibiotics. So again, I would probably look for other answers first. Another answer here is delayed presentation, fantastic. Wounds on hand, feet, immunocompromised, all fantastic answers, and would definitely be getting you marks there. Very good. Okay, so we've got a part 3 to this question. Let's get 2 minutes on the clock, and your time starts now. You confirm he has no known allergies. What pharmacological management would be appropriate? List 2 pharmacological management options. Doses are not required. right, time is up. Let's have a look at some answers here. So for here, we're going to be looking at Augmentin Duo Fort as your oral antibiotic of choice if there's no contraindications, no allergies there. For just your learning, so it does say dose is not required, but I try to sneak into there as well just so you can pick it up. There's the dosing there you want to be using, so 22.5 plus 3.2 milligram per kilogram up to 875 plus 125 milligrams, so standard dose for adult. 12 hourly, 3 days. That'll get you 2 marks there because that's really the best thing to be adding here. Paracetamol orally. Don't forget, pain relief. Simple things, being simple, and as I've said before, often analgesia and acknowledging pain as a contributor will get you marks there. So paracetamol or an NSAID or ibuprofen orally, both of those things would get you a mark. Now, take note, the antibiotic therapy as being the thing for it is going to be worth 2 marks, whereas those other things are going to be worth 1 mark there. Now, ADT booster, you will note that they have actually specified here that the ADT booster is actually within date and so would not need the top up there, so the ADT booster would not be worth any additional marks. Sorry, it was a trap. I set a trap and I can see some people have fallen for it. So we do have here Tetanus Prophylaxis Society ADT, sorry, and Augmentin Duo Fort, absolutely fantastic. And another response here, Augmentin and Nurofen, fantastic, fantastic. Well done, guys. I intentionally set some of these traps here. Yes, they're a bit pedantic, but you will see these things in the exam as well. So the more you can pick up on this kind of stuff now, this is the time to fall for those traps because you won't do it on the day. All right, we have another case lined up here, so let's get 2 minutes on the clock and your time starts now. Andrea Diaz, a 65-year-old woman, presents to the primary care clinic with a chronic cough persisting for the last 6 months. She describes the cough as intermittently productive with occasional yellowish sputum and notes occasional wheezing. Andrea reports gradual onset of dyspnea on exertion over the same period. She denies any fever or chest pain. Her past medical history includes hypertension, for which she takes amlodipine 5 mg orally daily. She has a 20-year pack history of smoking, quitting 10 years ago. She denies any recent respiratory infections. On examination, you find her temperature is 36.9 degrees Celsius, blood pressure 140 over 85, heart rate of 82, rest rate of 18, oxygen saturations 95% on room air, and body mass index of 23.5. Question 2.1. What specific examination findings would you expect to find with serious causes of chronic cough? List 5 specific examination findings. Alright, time is up. Time for answers. So here we have lots of potential examination findings that we would be wanting to look for. And so, of course, some of these would be hemoptysis on coughing. Are they able to actually produce things like blood? That would obviously have us all a little bit worried if that was the case. Weight loss, decreased breath sounds, prolonged expiration, pedal or sacral edema, elevated jugular venous pressure, pulmonary crackles to auscultation of the chest, and yes, there can be multiple different findings related to auscultation findings on that. Basal dullness to auscultation of the chest, unilateral or bilateral. Again, I'd probably specify just one for the actual exam itself. Resonance to percussion of the thorax or lungs, bone pain, neurological deficits, clubbing of fingers, one of those signs of chronic hypoxia, lymphadenopathy, and of course evidence of atopy, rash or rhinorrhea. This is one of those things where often we get a bit caught up sometimes and may not know, what are they looking for here? Just think, if this patient was in front of me, what would be the things that I would actually be looking for? With that, you're going to find stacks of answers. So here from the chat, we've got dysphonia. Oh, excellent. Yeah, that's one that's not on here, but would definitely get you a mark. Hyperexpanded chest, tick. Clubbing, tick. Fever over 38. Yes, definitely tick. And pedal edema, tick, tick, tick. Very well done. Also here we've got finger clubbing, reduced air entry, weight loss over 10%. Yep, another big tick there, definitely. And I really like how specific you've been as well. And peripheral edema, fantastic. Elevated JVP, definitely. Now we have a question here as well. I'm curious about examination for bone pain. Are you really checking all bones? You're not going to assess every single bone, but if you do happen to find that you examining them and they complain of pain through long bone or spine, you're going to be more concerned about things like myeloma or metastases into that space. And sometimes that can be one of the few findings you actually do elicit. So I think bone pain, if you were to specify spinal pain or metastatic bone pain, I think you'd definitely be getting a mark there. Hopefully that makes sense. All right. Of course, we've got question 2 on this case. Let's get 2 minutes on the clock, and your time starts now. What investigations would help provide a definitive diagnosis? Select 4 investigations. Pulmonary function tests, spirometry. Electroencephalogram, EEG. Full blood count, FBC, with differential. Chest X-ray. Thyroid function tests, stool culture, electrocardiogram, ECG, B-type natriuretic peptide, BNP, urinalysis, serum zinc. All right, time is up and let's get to the answers. So these answers are taken from the RACGP guidelines on investigation of chronic cough. So as you're no doubt going to expect here, pulmonary function testing to investigate for pulmonary features, yeah, it's a bit of a no-brainer. So spirometry is going to get you 2 marks. It's going to be really good bang for buck there, so definitely worth the most marks of these options here. Of course, full blood count with differential is going to be looking at our inflammatory type pathologies. Chest X-ray is going to give you a lot of anatomical details there, and low dose radiation, readily available, definitely going to be high yield. ECG will also score you a mark to help exclude cardiac causes or abnormal rhythms or perfusion. Can give you hints on cardiomegaly, for example, and so it's definitely going to be a mark. And B-type natriuretic peptide, again looking in that cardiac failure type picture, going to be giving you marks there. So as you've both correctly identified from the chat there, ADCH and ACDH, yep, agree, 100%. Now, again, look, we have 5 correct answers here, even though they've asked for 4. Always remember there's usually going to be more correct answers than options to select from, so don't trip yourself up and get caught up too much on that kind of thing when that happens. And there's very few times we need to check serum zinc, just throwing it out there. It's not never, but few times. Of course, we've got another question here. Let's get 2 minutes on the clock, and your time starts now. After appropriate testing, a diagnosis of mild chronic obstructive pulmonary disease is made. In addition to non-pharmacological management, what pharmacological management would be appropriate? Provide one specific pharmacological management. Doses are not required. All right, time is up. Let's get to those answers there. So, COPD, mild diagnosis. Our first line is going to be salbutamol, meter-dose inhaler as required. Again, you're not expected to know the dosing here, but 1 to 200 micrograms by inhalation with spacer, 2 marks. And of course, instead of that, you could use terbutaline, dry powdered inhaler as required. Again, for mild disease, you start as required medication and see if they actually need to have a stepwise increase from there. This is both in accordance with the COPDX guidelines as well as ETG. So both those sources are going to give you the same answer there. So unfortunately, Spariva, we've got from chat here, is not going to be giving you a mark there. Sorry. Used to be pretty much most people would just start people on tiotropium or ipratropium. Nowadays we're saying start off with the other ones first. And as we've got here, can never recall whether LAMA or LABA is best first up. Yeah, fair enough. As a rule of thumb, if you get a bit trapped here, salbutamol is usually going to be a pretty safe answer, and so feel free to kind of start there and work your way up. All right, well done, guys. This one is one of those ones that I don't think we often see mild disease at diagnosis, and I think that's one thing that we often stumble on. So do be mindful that the severity of disease at diagnosis is going to have a definite impact on what pharmacotherapy we actually start them on, acknowledging that the vast majority of patients that we diagnose are probably going to be in that moderate or medium bracket. So have a read through the guidelines, make sure you're familiar with them for the exam. If you want to get into a little bit more detail as well, they say that start off with SABA or start off with basic things first and reassess after 3 months of therapy. So as much as they can, try and go for 3 months before deciding whether or not you're going to up-titrate there. And then, of course, you'll be upgrading to LABA or LAMA monotherapy. All right, let's get to the next question here. So we'll get 2 minutes on the clock, and your time starts now. I think we have a bit of a problem here. There we go. Case 3. Grace Chen, a 24-year-old medical student, is planning to embark on an international placement to rural Cambodia as part of her medical studies. Grace is concerned about her health and safety during her stay and seeks advice on travel precautions and preventative measures against malaria. She has no previous medical history, takes Levlin daily for contraception, and has no known allergies. She does not smoke, drinks 2 glasses of alcohol on weekends, and has a BMI of 24. Question 3.1. Outside of malaria prophylaxis, what general travel advice would be appropriate for Grace? Give 4 pieces of general travel advice. Alright, time is up. Let's have a look at some answers. So again, remembering this is outside of the malaria side of things, and usually that's a hint to push away, or they're going to be asking other things about malaria later. General travel advice here, and this is one of those things that you probably need to have a little bit of knowledge about travel medicine, or spent a little bit of time learning bits about different parts of the world. So something that you probably won't be aware of, but if you are, fantastic. If not, don't worry, there's plenty of other ways to get marks, is that you need a visa to enter Cambodia. So you don't want them turning up on the day and not being able to actually enter. Probably more related to the medical world would be make sure they purchase extensive travel insurance, medical travel insurance, that should specify, prior to travel. And that's true of developing pretty much any overseas nation these days. You really do need to make sure you've got good cover, as most of the world will have horrendous medical expenses if you do end up becoming unwell and needing to access medical services. Again, getting into knowing specifics about places people travel to, they should be made aware that Cambodia has severe laws against drug offences. And so letting them know about that beforehand, although there's no high-risk medications they're bringing with them, as a young person, potential uni student that may make potentially poor choices, not saying anyone here would make those choices, of course, it's important to flag these things so that they don't get themselves in deeper trouble. And tied into that as well, be aware of local laws and customs. So lots of things that they need to make themselves know about. For instance, there's no mocking or making fun of the royal family, being very careful about taking photos in public places that may accidentally photograph military installations, things like that. Things that they probably need to be aware of before they get there. Now, not just specific to Cambodia, but many parts of the world, they need to make sure that they bring enough of her medications to last the trip. So they're taking Levlin for contraception. Some places do get a bit funny about contraception, not the case for Cambodia, but strongly recommended that she actually brings her supply of her regular medication there, as the supply of that medication may not be quite up to scratch, or perhaps even the correct medication, and just don't get into that trap there. Of course, general travel advice, so be cautious of unwashed, uncooked food or open drinks, and always a good idea to direct them to smarttraveller.gov.au for additional information and as a information source where they can get most of this information in a rather concise, nice, laid out way. It used to be the case that you were asked to register with Smart Traveller just in case. These days they say don't worry about having to register, but check in and check the travel advice before departing, as well as regularly throughout your stay. Coming in from the chat here, we've got Get Traveller's Insurance, fantastic. Pack a first aid kit, very good advice. Use a mosquito repellent. I'm going to be super pedantic here and say be careful with that one because they may class that as part of malaria prophylaxis, in which case you probably wouldn't get a mark for that one. Only drink bottled water, fantastic, it's going to get you marks. And fallen for the trap there, I'm very sorry. Outside of malaria prophylaxis, so using mosquito nets is probably going to fall into that same category as well. Yes, I get it. There's going to be lots of other diseases that they could get from mosquitoes in that region, but they are trying to push you away from that kind of direction, so I'd be leaving that. And this is one of those hints they're probably going to ask you other things that would involve mosquito nets later. As for drinking bottled water, yep, definitely. Barrier protection for sexual activity, oof, not on this list, but fantastic advice. And avoid medical procedures, again, not on this list, but also quite good advice, particularly when there may be some temptation if they're getting mates rates or whatnot while they're over there. So yeah, not on this list, but I think that actually would get you marks. Well done. All right. Let's hope that the system's working and the buttons work properly and we actually see the question in a decent time frame this time. Let's get 2 minutes on the clock and your time starts now. You discuss malaria prophylaxis. What non-pharmacological management options would you recommend to Grace? List 4 non-pharmacological management options. All right, time is up. Let's get to the answers. So in this case here, you're going to have noticed there's going to be that overlap there in terms of things like using mosquito nets. Now, I've intentionally made the last question and this question have that kind of vague overlap there because you will occasionally see this in the actual exam as well, where you answer a question, you think, fantastic, I've got that one. Then you get to the next question and you're like, oh, actually, I want to use that answer again. They intentionally try to make it so that you shouldn't use the same answer for more than one question within each case. And so if you see a situation like this, ask yourself, in which case would that be a more or most appropriate response? Use it there, remove it from the other question, and try and find a different response you could give. So what non-pharmacological management options do we have here? Things like cover limbs, so wearing light-coloured long trousers and long sleeve shirts in the evenings, sleep in sunscreened accommodation, how to tell I live in Mildura. Sleep in screened accommodation or using mosquito nets. Now, I wouldn't put or in there. That'd probably veer into overcoating. So that'd be a screened accommodation / mosquito nets that would be grouped together. You would only get marks for one of those responses. Now, you can actually get mosquito nets that are perithroid impregnated. I wouldn't be specifying that for this one because they have specifically asked for non-pharmacological management options, and one may make the argument that that's then a medicated option and would potentially be pharmacotherapy. it'd be pedantic as hell. I think if you're putting down just mosquito nets, that's enough. Now, of course, the simple thing is to just avoid outside activities between dawn and dusk. Those periods where mosquitoes are going to be most active, and staying away from them will definitely get you a mark. And, of course, avoiding perfume and aftershave. Turns out mosquitoes have great taste. They like our perfumes and aftershave as well, and will hunt you down if you deign to wear them. So some of the responses we have here is nets, repellent, long sleeves, all fantastic, and be born with thalassemia. You can recommend it as non-pharmacological management. There's not a whole lot they can do about that. So full marks other than potentially that last one. And of course, the let's go back here, sorry. Mosquito nets, bottled water, that's the response to the last one. The only thing I can think of is to add sleep in rooms with screens or closed windows. Yep, fantastic. I think there would potentially be overlap, and again, you would probably try and diversify answers a little bit, but I think if you got really, really stuck, you could always try putting that down. You wouldn't lose marks, you might just not gain additional marks, if that makes sense. Really, it's a barrier method, as you said for your last answer. There we go. All right, the final question for tonight. Let's get 2 minutes on the clock, and your time starts now. You discuss malaria prophylaxis. What pharmacological management options would you recommend to Grace? List 2 pharmacological management options. Doses are not required. All right, time is up. Let's have a look at the answers here. And we've got multiple options for you. So we've got Malarone, or atorvaquone and proguanil. I can never pronounce those properly. Again, it has specified here that dosing is not required. And so while it's fantastic to know these things, and I think you would really show that finesse and polish if you were to mention things like taken with fatty food or full-fat milk daily, but I don't think you would need to know the actual chemical dosing there. Now, for your knowledge as well, these should be started 1 to 2 days before entering a malaria-prone zone and continuing for 7 days after you leave the malaria-prone zone. Doxycycline is oral, also a fantastic option. Again, it's that starting 1 to 2 days before entering and continuing for 4 weeks after leaving. So there's a substantially longer period that you would need to be treating for if you're using doxycycline. Now, a pharmacological option would actually be regularly applying DEET-containing insect repellent on exposed skin. That is a form of pharmacotherapy. It's a topical therapy and would be worth a mark. So if you ever get stuck for these kinds of things, ask yourself, is there anything a little bit more out of the box that you can think of that might be appropriate here? And as Jenna has pointed out in the chat here, this is going to be a mefloquine resistant area, and so mefloquine in this instance would not get you marks. If you're ever uncertain, I think it's probably safer to just not put down that option and use Malarone or doxycycline preferentially. For tolerability and just ease of not having to continue for quite so long, Malarone's a fantastic option, but doxycycline's also very good. Be mindful that there can be interactions with the Levelin as well, and that should also be taken into consideration, along with things like patient preference, of course. So we've got answers here of doxycycline, yes, and presuming it's mefloquine resistant, and doxycycline till 20 days after travel. So smashing out of the park, guys. Very, very well done. So that's it for tonight. Hopefully you have found this helpful, and of course I'm going to keep doing these live streams right up to the exam as well, so if you found it helpful, tell other people. The more people we have here, the more engagement we get, I think at least. The better the answers are, the more chances we have to have people fall for traps as well as get diversity in the answers and learn from how everyone's answering questions as well. I'll of course stick around for another minute or two if anyone wants to throw anything into the chat they want to comment on. If there's, again, particular topic areas you would like more questions on. I've tried to go for a little bit of a broad base tonight, and hopefully that kind of shows. And I'm trying out as well to talk through some of the questions, that way they can be cut into a podcast later. Let me know, was it distracting? I know fumbling up a couple of the questions probably didn't help. If it is too distracting, I'm happy to actually go and record that voiceover section after the live stream, so that it can be put in there. But just let me know, and happy to kind of meet whatever works for you guys. Obviously, the people turning up and attending the live streams, I'm going to preferentially treat you guys because you are the ones that are putting in that extra legwork, and I want to reward that in some way, shape or form. Cool. So we have a response here. So you turn off sound during the 2 minutes, not distracting. Cool. Is that also, are you finding that the little music ditty that plays, is that distracting? Is that why you're turning off the sound? If so, let me know, because I can always turn that volume down a bit, or potentially try without it. One of the reasons why I have that music there is a little bit sneaky. One, it's to appease YouTube. YouTube really doesn't like silent streams with static images. There's a certain amount of data that it expects to see in live streams, and if there's not as much data coming through, it kind of thinks, oh, is this live stream paused, is it messed up, and it can muck things up there. So that's one of the reasons why I do it. The other aspect to it is to just try and give a little bit of kind of background noise. So yes, it's distracting, and yes, it's a tad annoying. Yeah, okay, let's try without it for next week then. I'm very, very happy to do that, and we will see what the feedback is. I can keep it out of the videos that get cut up later then, and we'll crack on with that. Very good point that it won't be in the exam as well. I did have feedback from last year saying that in the exam they hummed the tune to themselves all through the exam, and it gave them a little chuckle, gave me a little chuckle as well. But yeah, if you guys are finding it distracting, I'll take it out for next week. Excellent. Okay. With that then, we might leave it. We have finished up a little bit earlier than usual tonight. I think we ran through some of the teaching questions pretty quickly. One more thing for the chat. I guess if you read it, that fills in the silence more. That is very true, yes. And if you didn't find the reading through overly distracting, then that's probably a good way to fill it up. I guess we'll find out next week. If the stream suddenly dies, you'll know what's happened, and I'll restart it again. We'll go from there. So, catch you guys next week then. Have a great week. Look after yourselves, and I will see you next time.